Hello, my name is Brennan Martino, and it is my privilege today to talk with you about my case, A Tale of Two Tumors, Zollinger-Ellison syndrome in the setting of Men 1. The objectives of this talk are to describe the pathology and connection between Men 1 and Zollinger-Ellison syndrome, understand the clinical presentation of these disease states, understand the diagnostic workup of ZES, and understand treatment modalities for ZES. Our case is a 42-year-old female with history of persistent hypercalcemia who presented to the ED with right flank pain. CT of the abdomen and pelvis showed nephrolithiasis, as well as masses in the pancreatic tail and right adrenal gland. She was also found to have hyperparathyroidism and an adrenal adenoma and was referred to endocrinology. Genetic testing for Men 1 syndrome was positive. The patient underwent distal pancreatectomy and right inferior parathyroidectomy. Patient then developed symptoms consistent with gastroesophageal reflux and was found to have elevated gastrin levels. She was trialed on H2 blockers and PPIs with limited success. Chromogranin A and pancreatic polypeptide levels were elevated, raising suspicion for gastrinoma within the head of the pancreas in the setting of her Men 1 syndrome. Octreotide, sucralfate, and misoprostol were added to aid in symptom relief. However, she developed an allergic reaction to octreotide and was switched to lanreotide. She was referred to GI for possible gastric outlet obstruction and was found to have diffuse esophagitis with multiple gastric and duodenal ulcers on endoscopy. Dotatate positron emission tomography was obtained and showed intense uptake in the second and third portions of the duodenum, as well as the uncinate process of the pancreas, with accompanying calcifications, raising concern for gastrinoma. This was supported by a positive secretin stimulation test. The patient underwent endoscopic ultrasound with biopsy of the uncinate process, which was negative for malignancy, and no discrete masses were appreciated. Given the lack of discrete operable masses on imaging and negative biopsy, it was decided to perform serial CT pancreas scans with plans to repeat EUS with biopsy of the duodenum and then proceed to surgical excision of the gastrinoma once identified. Here we have imaging from her PET CT and EGD with EUS. On the PET CT, you can appreciate the hypermetabolic activity within the uncinate process of the pancreas, as well as the second and third portions of the duodenum. The EGD images, seen on the right, show grade C esophagitis and diffuse duodenitis with large cratered ulcers. The EUS shows the main pancreatic duct at the head of the pancreas, without evidence for discrete masses. There are two main classifications of Zollinger-Ellison syndrome, sporadic and Men 1 associated. Roughly 20% of patients with Zollinger-Ellison syndrome occur in the setting of Men 1. Men 1 is classically manifested by the three Ps, pituitary adenoma, pancreatic mass, and parathyroid hyperplasia, and can be confirmed with genetic testing. Given this association, physicians should have low threshold for screening for ZES in Men 1 patients complaining of gastric reflux and dyspepsia by obtaining a serum gastrin and chromogranin A level. A secretin stimulation test can also be used to distinguish Zollinger-Ellison syndrome from other etiologies of hypergastrinemia, such as antral G-cell hyperplasia. Gastrinomas can be very difficult to localize, and endoscopic ultrasound is generally recommended when surgical excision is being considered, as it is superior to CT imaging modalities in tumor localization. First-line management for Zollinger-Ellison syndrome is with acid suppression therapy, including proton pump inhibitors and H2 blockers, for gastric pH goal of greater than 4 to prevent erosion and ulceration of the GI tract mucosa. In patients refractory to these agents, prostaglandin analogs such as misoprostol can be added to protect the GI lining. In addition, many neuroendocrine tumors express somatostatin receptors, and thus there has been investigation to the use of prostaglandin analogs, such as octreotide and lanreotide, to reduce gastric secretion in patients with Zollinger-Ellison syndrome. In addition to suppressing acid secretion, somatostatin analogs have been found to have anti-proliferative effects on neuroendocrine tumors. Pain management is often required for these patients to help control symptoms. Fortunately, surgical cure rate for gastrinomas in the gastronoma triangle is roughly 80%, as long as metastases have not occurred. Thank you.